Welcome everyone to the International Childbirth Initiative webinar series on the 12 steps to safe and respectful mother-baby family maternity care. My name is Michelle Scaratharian, and I am the coordinator for the International Childbirth Initiative. This is step 2, where we will address the importance of reducing financial barriers to safe childbirth through the provision of free or affordable care with cost transparency. What is the International Childbirth Initiative? At its core, ICI is an implementation and quality improvement process that strives to achieve the 12 steps through self-evaluation and a reflective process at the facility level. It also refers to our global resource network of facilities who strive together to share their learning and improve the provision of care. ICI was created through a joint effort between the International Federation of Gynecology and Obstetrics and the International Mother-Baby Childbirth Organization. It is now comprised of more than 20 partner organizations and continues to grow. We are open to all birthing facilities who are willing to commit to delivering safe and respectful mother-baby family maternity care. I'm very happy to introduce today's presenter, Vicky Penwell from partner organization Mercy in Action. Vicky is the founder and director of Mercy in Action Vineyard Incorporated, a nonprofit NGO that focuses on the crisis in maternal and newborn survival worldwide. They have been establishing and funding free birth centers for poor families in the Philippines for more than 30 years. To date, more than 16,500 babies have been delivered at no cost to the parents with excellent outcomes. Mercy in Action improves maternal child health and healthcare through direct provision of care, as well as through global education provided through their accredited College of Midwifery, based in the USA. Additionally, Mercy in Action has established successful birth centers in the United States that serve all pregnant women, regardless of their ability to pay. Vicky lives with her husband in the Philippines and travels widely to teach. Please welcome Vicky Penwell.
Thank you, Michelle. I'm glad to be here today. So Mercy in Action's purpose is to improve maternal and newborn health and healthcare through excellent and compassionate maternity care in all settings. And we have actually been doing this for 40 years because we started for the first 12 years in Alaska before we started working in the Philippines. And then we have bookended that experience in the United States also by setting up a model birth center along this model in the United States a few years ago. But the bulk of our work has been, and the bulk of our research has been in the country of the Philippines where I live. In talking about step 2, I want to really focus on the fact that we have decades of research that shows that lack of money and discrimination, and that discrimination often over the issue of poverty and lack of money, are the greatest barriers to timely maternity care. For years, people thought we just needed to fund the building of more hospitals or clinics. And now we realize that if there are barriers that don't allow people to reach those facilities, then it doesn't matter. So our main goal in Mercy in Action is to seek to remove those barriers in order to save the lives of mothers and their newborns. Step 2 addresses this. So in the next 3 slides that are in bold, I'm going to just be reading the steps so that we all have that as our framework to our discussion today. Step 2 says, respect every woman's right to access and receive non-discriminatory and free or affordable care throughout the continuum of childbearing. Inform families about what charges can be anticipated, if any, and how they might plan to pay for services. Make costs for prenatal education and antenatal, intrapartum, and postpartum care visible, transparent, and in line with national guidelines. Include risk pooling for complications, which means no additional charges if there's complications or a cesarean birth, so that no one's tempted to maybe not do what actually needs to be done medically if the person doesn't have money. Forbid under-the-table payments and routinely enforce this rule. And under no circumstances should a woman or baby be refused care or detained after birth for lack of payment. I want to start off with a little case study, Too Little, Too Late. This happened just a few months ago in the country where I live, in the Philippines. This is a screenshot of an actual news story about this lovely young woman, Kathy, 28 years old. She was having her third baby. She had a licensed midwife who recognized the signs of a problem after childbirth and sought medical care. And this woman was turned away by 6 hospitals. And at least one of those hospitals is on record as having asked for a deposit of 30,000 pesos to admit her. After she finally was admitted after being turned away by 6 hospitals, it was too late. She died. And this was an incredibly tragic case. One of the midwives that works with Mercy in Action knew the midwife that cared for her. This was such a distressing situation. The midwife was going to quit her profession. Of course, the family was devastated. And there are 3 more orphans in the world. So even though when we talk about this step, I want to stress that no one size fits all for this step 2. But we can agree that this kind of situation should never happen to anyone. Why do we need step 2? I think it's important that we realize that this case study and the story I just told you is not unique. I wish it was, but it's a common story all over the world. And there are many common stories that we hear over and over and over, and my news feed is full of them. Every week, I get stories from somewhere in the world along one of these lines. A woman in labor being forced to pay bribes to get care. Sometimes that means bribes to get in the door. Sometimes that means bribes just to have someone pay attention to her and give her care once she's admitted to a facility. Being refused care if you can't pay a deposit or pay the full fee at the door. This is something we have seen for years where I live, and it is not unusual to have someone show up at our door that had already been refused care somewhere else because of their lack of ability to pay. For years, we had a birth center in Manila where it was in a very, very populated area, and it wasn't uncommon to have people coming that had already been refused care a few times at several different places. So you can imagine this woman in labor going around trying to get admitted somewhere. The other story that's still way too common all over the world is after birth, a mother and her baby, or one or the other of them, being held against their will in the hospital because they can't pay the bill. And so they're not allowed to leave. Oftentimes they're actually medically discharged, and then they're just not allowed to leave. In extreme cases that have been documented, sometimes that goes on for months. There was a case in the Philippines a few years ago where a baby was 9 months old and had never been allowed to leave the hospital. There is a law against this in many countries now, but it still happens. It's still way too common. The other reason I'd like to point out why we so need step 2 to be implemented is that maternity care is unlike other healthcare needs. And I'm very aware that there is schools of thought about healthcare and whether or not it should be free or whether people should be required to plan ahead for it and to pay for it. I want to say that when we're working with the extremely poor, which is who Mercy in Action has worked with for decades, the people that really are living on the edge of catastrophe, people that may actually are living in some sort of a recovery from a natural disaster, or prisoners or people living in refugee camps, there really is no extra money to save toward a birth. But once pregnancy begins, and once labor begins especially, this really is very, very unique situation and unlike other healthcare needs. One of the reasons it's so unique is that birth is so often normal. So birth is so different than other medical emergencies we could think of, like broken bones or appendicitis or something, that's just gone wrong in the body. Birth is natural. It's the reproductive system usually works just like the other systems of the body works, and people know that. People know that babies come out all the time. They're usually fine. So when there isn't enough money to pay for a birth attendant or to go to a facility, people will gamble. They'll gamble on the fact that they have a very limited number of coins in their hand, as it were. And the very, very limited income. And remember that still a large population of this world lives on less than $1 or $2 a day, the equivalent of $1 or $2 US dollars a day. So there's not enough money. So they're thinking, well, we have to have food. I mean, we can't live without food. We have to feed the family. We can't live without water. And oftentimes water, clean water, is something you have to pay for. We know that's just not going to happen. We need a roof over our head. It's very, very dangerous to be homeless. We have to have a roof over our head. We do have hopes and dreams that maybe at least one of our children could attend school, which is oftentimes that has costs involved. So they're looking at a pregnancy and they're thinking, well, birth is normal. Your last baby was fine. Or most people in this village have babies at home and they're fine. And so we're going to gamble. The problem is that it's a very high stakes gamble. And when you roll the dice and lose, you lose really, really big. Because if something goes wrong, especially right at the moment of birth, if a baby's not breathing, if someone's there, resuscitation is actually usually pretty achievable with a newborn. But if no one's there, then that life is just lost. Same with hemorrhage for a mother. If a skilled birth attendant is there with a basic kit of equipment and medications, then that's a fairly easy thing to stop with no long-term effects. But if not, that can mean the death of the mother. So it's a gamble that people make because they're forced into it. And looking at the alternatives, it seems like the only thing they can do, but it's a very high stakes gamble and big costs when you lose. The other reason maternity care is so different from other healthcare needs is that labor is a timed event. There's no chance for a do-over. Once you start labor, like things are rolling. And so that whole picture, which I have seen firsthand of people arriving at your door after already having just been going around town, begging someone to take them in, not having money, that's very heartbreaking because labor is quickly moving forward. And if someone doesn't open the door, the baby's gonna literally be born out on the street. Whereas with other healthcare needs, you have a little more time when you realize that maybe something's wrong. Sometimes people will have the money and they pay for the baby, but it causes this long-term, very, very negative and destructive spiral of events. We have heard about this in countries where there is not universal health care, that families have to declare bankruptcy after paying for a hospital bill for having a baby. And that's something that we have some data on. In a different kind of a context, we find people doing things like selling land to pay bills, which is a way of coping, but it's a very destructive coping mechanism because once you've sold your land, then your poverty is probably going to spiral downward. Land is such a value and it should be passed on in a family, but oftentimes it's sold. And where we live, where there are people that used to own land and tell us that they sold it, it often was to pay for a maternity bill. It was to pay for a beloved wife that had to be rushed to the hospital and needed care after childbirth or during childbirth. The inability to pay for basic needs. After you've paid your hospital bill, what happens then? I'll always remember the one night we were called and asked to bring our ambulance to a local private birthing center because a family there had a baby, had been asked to pay for it, had cleaned out every last peso out of their pockets. They didn't even have the fare to ride public transportation to go home. They had literally every single peso they had was taken from them, and they asked us to at least give them a ride so they could get home with their newborn baby. And then what are they going to buy for food until they can work again? The other thing that we see is avoidance of further medical care, that people are scared once they have a bill at a hospital, or once they've sold land and have nothing left. Oftentimes they want to avoid any further medical care, and that can have devastating effects, as we know. One night a few years ago, I remember we had a woman in labor at our birth center, which is a midwife-led birth center out of hospital, and she had a complication arise where she really needed to be in a higher referral level hospital. where she could get emergency care. And when we told her that we wanted to transfer her, she broke into tears, just broke down and said, I can't go to the government hospital. I had a baby there 2 years ago, and they were holding me for not paying the bill, and I escaped. I basically snuck away, and now I can never go back there. So this is really serious because she had a problem that night that could have cost her life. So what we did was, of course, we took her to the hospital. We negotiated. Our nonprofit was able to pay her bill from 2 years previous and get her care. But this is the kind of thing that happens to people once this spiral has started. And then the other thing is the next childbirth is going to be home alone. If they really did use up all their resources, if they feel like we can never go back to the hospital, but there may still be more babies in their future, and they're not going to seek any kind of care the next time. All right, let's talk a little bit about this issue. In the human rights language, they call holding someone hostage because they owe you money, they call that a debtor's prison. And many of you will remember from history, we used to have literal debtor's prisons where people were put if they couldn't pay a bill. But these have been banned years ago. And in almost every country has some form of a ban on imprisoning someone that owes you money, as this is now considered a human rights violation. However, this is still a common practice. And I remember when they passed the law in the Philippines saying this was illegal, and I was, really celebrating. And then it was probably, maybe over a decade ago, I'm trying to remember. And anyway, I was teaching on the different needs of maternity care, and really found out that it's still going on everywhere. The doctors in our local hospital said, yeah, that still happens. We don't have, this just, people get held if they can't pay. So even if you've had a bill passed for a decade, don't expect just because something's a law that it's not happening wherever you are. And then women are still being refused care at hospitals in labor, even with complications, if they can't pay at the door. Now, some countries have banned this also, and maybe they just refuse them care up to the point of hard labor. Other countries, people are still being refused even in hard labor. And again, depending on what the laws are, this practice might still be going on. It's extremely common. Okay. Maternity care providers, basically, we don't have control over all of this, but we need to know what programs are available to help low-income patients within the system. We need to know how the system works, if there are laws, and are those laws being followed. It's not enough for us to just say, well, I just work here and I have no control over these kind of issues. If the system is inadequate, and we kind of are at a place in history where we have to admit that it is inadequate in ways, we have an obligation to advocate for improvement. So step 2 is just asking that we would be concerned about these issues, and that until systems are adequate, we may need to make some personal decisions and even make some sacrifices to provide care. We may need to advocate. We may need to be very creative about ways that we can still help people if we are working within a system that is inadequate or is not following the law in our country, or is not providing the care that every pregnant woman and her baby deserves. So step 2 in practice. Now, I said earlier, no one size fits all. And that is really true of this step. Some facilities or providers will charge by necessity because they're not in a country where there's universal health care provided. And in that case, then the care should be affordable and cost transparent. So there should be no hidden fees. Everything should be upfront. Everything should be posted, what the costs are. And those costs should be very carefully thought out to be fair and equitable to the population. In other countries, the providers don't have to charge. The government or an insurance or some other entity, perhaps even a private foundation, provided payment already. In those cases, it's our obligation to make sure that absolutely no bribes are getting added to that free care, that we really make sure that we maintain ethics in that case. And we're really watching to make sure no cash fees are added, even to insurance, even to health insurance. Cash fees should not be added to that. So whether or not we have to pay, or charge, whether people have to pay or whether that's covered, we want to make sure there's not added fees for emergency care. So that would be a really important standard to keep, that there would be like a global fee, and it wouldn't change based on whether the woman needed a little bit of oxygen, for instance, or an IV or a cesarean section. And I want to say again that governments and private medical facilities and nonprofits can all partner together for creative solutions to the current crisis in maternity care. I would love to see the day when we no longer have a crisis in maternity care, and this is not an issue, but it is an issue. We are having a very high rate of maternal and newborn deaths and stillbirths right now. And it really behooves all of us to care about this issue and make sure that we're not throwing up a barrier where people can't access care. So whether or not we have to charge or whether we don't have to charge, the concept's the same. And that concept is one of respect, with the pregnant or the birthing or the postpartum patient at the very center of care. And there shouldn't be any model of care where that patient is left out or punished or discriminated against for not having money. And that's the whole point of step 2 in practice. So I was asked to give a few examples of what this looks like in real life. So this woman represents the women that live up in the mountains behind where our birth center is. We'll call her Joji. So one of our birth centers in the Philippines caters to the tribal people that live up in the far mountains. We actually very strategically chose land and built our birth center right at the foot of the trail that winds down out of these mountains, because this is the population that was very underserved. And what happens to Joji when she goes into labor? Joji lives in a mountain village that takes 3 or 4 hours to hike to. That's on a good day. If the sun is shining and you're wearing sturdy hiking boots, you're in fairly good shape. Now, Joji is going to take this trail in labor at night, possibly in the rain. This trail involves fording the river several times as it winds in and out of the trail. So she may actually be fording a fast-moving river in labor. And I remember one of our patients, she actually was in hard labor when she was fording the last bit of the river, and her husband told us he was terrified. He told her, keep walking, keep walking. He was so afraid the baby might come out and be swept away in the fast water over, someone's waist and chest. So this is her experience in labor, is walking, hiking down this scary trail with steep, narrow, path and precipices that you could fall off of. When she gets to the bottom, what's she going to find? She doesn't have money. Is she going to be turned away from care? And this is why step 2 is so important. At the bottom of this trail, and I'm telling you about a literal trail, it could also be figurative all over the world. Is she going to find a welcome open door? Is she going to find someone that takes her in and says yes and not no? The other picture I put in this slide I wanted to talk about is if Mercy in Action has an ambulance, and I think it's very important. We have another step later on in the 12 steps about having emergency care, but we need to always have transport. We need to always be able to meet someone at the point of a birth complication or emergency and get them referred to higher care. In this picture, we're actually driving people home after their childbirth, taking them as far as we can take them. But we also use our ambulance. If we were to meet Joji at the bottom of this mountain and she had a medical complication and we couldn't take care of her, we don't just send her on her way walking. We're going to put her in our vehicle and take her to a safe place. My second example, I call this a rainy night. So Marife went into labor on a rainy night, and her husband, a very kind man, a Tracy driver, so he drives a little motorcycle with a sidecar for his income. He only earned what the family needed to live on day to day. And when Marife went into labor, he drove her to the hospital, but they would not admit her. They said, "Where's your deposit?" They had not enough money. All he had, what he had in his pocket for driving his Tracy that day. So he loaded her back up and he took her to another hospital. And it was the same story. They walked in the door and they were sent right back out the door on this rainy night. Now, outside of the door of the second hospital was a cab driver who saw them get refused, saw them go in the door and come back out of the hospital, and her obviously in hard labor. And he said, "Go to Mercy in Action. I'll tell you where they are. I know they'll take you for free." At the time this couple arrived at our door, the woman was in hard labor. And our midwives met her and immediately took her to a bed. And I want to tell you that her husband at that point, we had to stop him from getting down on his knees and begging. He was so afraid that we would turn them away again. And he knew this was his last chance. His wife was about to give birth. And I've never seen, I just remember that I was just so heartbroken that this husband, this father, was ready to beg. He was ready to grovel. He was ready to do anything if we would only take his wife. And so we were trying to care for her while also reassure him, "Please, please, sir, don't beg. Don't get on your knees. We're going to take care of your wife. By the way, can we get you a cup of coffee?" The relief was just so palpable from both of them that on this rainy night at the third place they went, they weren't refused. Now, it was only actually less than 10 minutes till Marife gave birth. So if we hadn't been open, if we hadn't said yes, they would have been delivering their baby on the rainy night. These are the stories that we have lived for the last 30 years in the Philippines. And this kind of desperation exists. We need to be able to meet people both at the bottom of the long trail and on those rainy nights when everyone else has said no. Okay, those are my stories. Now I'm back to the actual text of the step 2 indicator, and I want to explain what this looks like because there's always a lot of questions like, what does this mean? Do we have to be free? What if we can't? So these are our indicators. How do we know we're meeting step 2? 1, there are no cases in which women, newborns, or infants are refused care or detained after care due to inability to pay. So that's a measurable indicator. We didn't turn anyone away and we didn't detain anyone. So both ways. Number 2, survey and interview responses from women indicate that the fees they were asked to pay meet the advertised rate. That's very simple. So if you are a fee for service practice, you just have to make sure that when women are interviewed afterwards, they're asked, did what you thought you were going to pay, is that what you paid? Were there any surprises? Were there any under the table payments or bribes or those kind of things? And that they can answer and say, no, yeah, it was what it was advertised. It was what I expected to pay. It was fair. Okay, the third indicator is that there are informational posters or signs showing all relevant costs in ways comprehensible to families. So if it needs to be pictorial, if people don't read, it needs to be simple language in the language that people, or the different languages. We just need to have posters and signs that say, these are the costs. This is what you can expect to pay. And those should really be posted at the entrance to the labor and delivery unit and at the discharge and at the cashier. And those of us that run facilities or have a birth practice need to be sure that there's no disconnect between what people were told at the door and what they're going to be told at the cashier window when they pay. So this information includes information on how families can report non-adherence to the policies and requests for bribes. You have to realize how incredibly difficult it is if a woman is in labor, and I have heard stories of women being in stirrups with their genitals exposed, and somebody has come up to them and asked them for a bribe. It's very hard to refuse or to not feel incredibly vulnerable when that happens. So we need to make sure that doesn't happen, but we need to have a mechanism that there's a safe way that after a woman is out of the hospital, and safely, outside of that threatening environment, that she could say, yes, somebody came up to me right when I was in stirrups and asked me for a bribe, so that we can stop that kind of practice. All right. I was also asked to relate this step to some of the other steps of the ICI. So this step absolutely relates to step one. Step one is about dignity and respect. And giving people access to care is such an issue of dignity and respect. Letting them in the door when they're in crisis, in labor, or in a birth complication, or even pregnancy, to say you are valuable because you are in this vulnerable state. We're gonna take care of you. Step three is providing care based on needs, and again, this step relates to that. We're talking about pregnancy and birth being a need someone has, and being able to meet them at that point of need. Step six addresses evidence-based practice. We have absolute evidence that the practice of charging people cash at the door does throw up a barrier that some people can't get across. And we do know evidence-based that when we remove that barrier, that people have better outcomes. We have less loss of life, we have less stillbirths. And this past year has really shown us that when people are avoiding healthcare for any reason, whether it's a lack of money or a pandemic, that they're going to have, we're seeing more stillbirths, we're seeing more bad outcomes. Step seven, avoid harmful practices. Well, this is a one. Not letting someone in the door when they have a need, when they're pregnant or in labor, is a harmful practice. Holding people against their will, holding babies in a facility instead of letting them go home and be in a nurturing environment. Those are harmful practices we want to avoid. Step eight, enhancing wellness. Obviously, this plays into that step. And step nine, provide emergency care. The first case study I told you about Kathy, who died because she was turned away from 6 hospitals. Her midwife got her to care in a good, timely fashion. She would have probably had no ill effects at all if the first hospital had accepted her, maybe even the second or third. But by the time she started getting down the line, she was in an emergency situation. And the last hospital that refused her refused emergency care. And then it was too late. So these are some of the steps that I thought it related to. It actually might relate to even more of them, but those are the ones that I chose. Okay, what's our take-home message as we wind this up? The take-home message is that maternity care must be available to all at the point of need during pregnancy. So again, remember, not one size fits all. Some facilities will by necessity need to charge a fee, others will not need to, but we need to be able to meet the woman and her newborn at the point of need. And it should be during pregnancy, ideally, so someone doesn't go with no prenatal care, but it absolutely must be at the point of labor. So however we need to be creative to make that happen, we need to do. We really need to take down those barriers that keep her out. Okay, number 2, take-home message. No one should be held in post-birth debtor's prison. So this is very important. If somebody leaves your care and still has a bill, you have every right to invoice for that, to help them find creative solutions for how they may pay that, but not detain them. And number 3, no one should be discriminated against while seeking maternity care, nor refused care for any reason. So that's the heart of the steps. There's a lot of ways to achieve them. Okay, I'd like to give an acknowledgement here. Every time I tell stories, it makes me think that we want to acknowledge our midwives who serve the mothers and babies in Mercy in Action, because without them, without their endorsement of and commitment to the principles of the International Childbirth Initiative, we would not get the excellent outcomes that we do. Now, at this point, we're up to around somewhere 16,500 births so far. We have excellent outcomes. We've been able to show a maternal and newborn mortality rate that's 4 times better than the country of the Philippines statistics as a whole. And we're very proud of that. And we really want to acknowledge that we feel like a lot of that success has been because for years, we have followed these steps, and all of our staff is very committed to this. As far as resources, one of the best resources I can send you to is whatever country you're in. That country probably has some existing programs in place, has some policies in place to help pregnant women receive what they need to survive and thrive. So find out what the country you're in has available. And then after that, know that it's our responsibility to know what's available locally, to know if there are special programs available locally. Those might be government, they might be from churches or from some faith-based group, it might be from an NGO. And we need to advocate for there being appropriate programs in place for what pregnant women need. And advocate if we realize the system isn't meeting the needs and the systems aren't in place, then we need to be able to advocate and look for how could we support the health and healthcare needs of all the pregnant women and newborns in our local area and in our country. And then I wanted to put this up. This was something that the ICI people brought to my attention really recently. The World Health Organization just in 2020 published a document called Ending Hospital Detention for Non-Payment of Bills, Legal and Health Financing Policy Options. Has a lot of creative ideas in here, not just don't do it, but a lot of ways to meet this step on that point. So wanted to put that up as a resource. And then I have a couple slides here that, and this is just seriously a tiny bit of the references that I have found really recently on all the issues I've talked about to back these up. Really, truly just a tiny bit. There are so many. So with that, I'm going to stop sharing and turn it back over to Michelle.
Thank you, Vicky. This is fantastic. Thank you so much for sharing this wide range of experiences that you've had. And it's really, I think, a very good introduction for people who are just starting to think about step 2. So I want to just start off with a few questions. This is a question that we're asking all of our presenters. Why do you think step 2 is an important step for a facility to prioritize? As they're looking at the 12 steps, all of them obviously are important. Mm-hmm. What would you say to a facility when they're considering their own need to address step 2?
Sure. I think step 2 is fundamentally a question of access. So access to care, and we need people to be able to get in the door. We often say pregnancy should be the ticket in the door, nothing else, that they would at least be able to be evaluated in labor or in pregnancy. So whether or not we're able to offer free care or meet all the needs that she has, it's really an issue of access. And it's also an issue of justice, of not holding people hostage against their will after care. It's really an issue of treating people like we would want to be treated, or how we would want our own sisters or mothers or daughters to be treated if they were pregnant. So it's a pretty basic step for the whole, all the steps are important, like you say. It's a basic issue of access.
No, but you're right. If they can't get in the door, then are the other steps relevant? It's true. So what would you advise the staff of either a public or a private health facility who feel that offering affordable or discounted care for patients who are unable to pay isn't feasible or realistic in their setting?
Yeah, that's a good question. And that is a very real question in places where universal healthcare coverage doesn't cover the cost of the providers for maternity care. I think, like I said earlier, the first step is just to not say no at the door. Let people in the door and at least evaluate them. And in many ways, this is the same issue that midwife-led facilities have. If we're to care for lower risk women and we find someone is higher risk, sometimes we have to refer them. I think it should be the same way when money is involved. Let someone come in the door, let them be evaluated, find out if they really are having a normal pregnancy, or is there some crisis why we would really need to advocate for them to get care? So we just need to not say no at the door based on, do you have the money, to get in the door. The other thing I would say everyone can start with is make sure that there's no bribes being charged anywhere. Crack down on bribes. That should never happen. And stop the practice of charging on top of what the government might already offer as far as aid. And just really want to stress that we need to be watchful for the emergency cases. That the access to care and possibly referral is incredibly important if there is a complication or an emergency going on. So that's a place to start. We don't need to get overwhelmed by thinking we're not ready to offer it free. We do need to remember that piece of affordable and transparent, and we can all start there.
And I wanted to ask you about how Mercy in Action has engaged in advocacy to make care more affordable, both in the US and in the Philippines.
That's a great question. I think our advocacy mostly takes the form of creating models that show what's possible. So before going to the Philippines 30 years ago, we had the 12 years before that, I was running an easy access or what we call an open access birth center in Alaska, where we proved you could give high quality care and have really great outcomes and not turn away anyone that couldn't pay. We did it with a sliding scale based on income and family size. So it was a little bit of a Robin Hood, kind of a scheme. The people that can pay will pay for the people that can't. When we started in the Philippines 30 years ago, just about now, it was January of 1991, the needs were so urgent and women were dying in childbirth and newborns at such high rates that we really had to start. And we started with a donor sponsorship program so that we could afford to not have to charge the patients. There was a lot of donors involved. Later, we were able to come up with some of our educational money went to support the clinics. As soon as the Philippines got a national health insurance program, then we started billing that. So that helped with the support. So our models kind of shifted and changed over the years so that we didn't ever have to ask the patient directly to pay. But now in the Philippines, we have a way of billing the insurance. In 2015, we circled back and started another nonprofit birth center in the United States because, again, we wanted to show what was possible. We were being told that in the United States that won't work, that we have to charge the patients. Midwives can't survive if they don't. And so we started a easy access birth center in the United States. No one was turned away for lack of pay. And we were able to show that we could be a viable option, that we could make a birth center that worked in the United States, just taking either a sliding scale or Medicaid, not charging on top of Medicaid or not charging on top of private insurance. So we proved that it could work as well in America as in Asia, that if you're committed to offering high quality maternity care without any barriers of money being an issue, our model works anywhere. And so we're always glad to consult with anybody that wants to try our model in any country. But that has been our basic advocacy, and keeping really good records to show that it's working, that we're getting great outcomes, and that it's viable even in a country like the US where there isn't as many other options maybe for people that are pregnant.
That's fantastic. Thank you so much, Vicky. So with that, I think we're going to close this session. I really appreciate you taking the time today to participate in the 12-step webinar series. We really appreciate everyone who's taken the time to watch this step 2. We hope that everyone's going to go on to watch the rest of the steps. And then also we are going to have a space, I think, for everyone to ask questions to you offline in the future. We're going to, in our forum, in the ICI forum on our website. So if people after watching this step have follow-up questions, we may be pointing them your way.
Absolutely.
Thank you so much. And thank you to everyone for participating. And we wish everyone the best in executing all of the 12 steps.
Thank you, Michelle.